Hi everyone. In this lecture we're going to talk about sensation and pain. And we have already been over the sensory pathways, so there isn't much to say in that area. But there are a number of kind of gaps to fill in. We haven't talked about sensory receptors yet in the course. And we'll talk about some mechanism of pain and some pain syndromes. So first let's just go over the sensory receptors. There are many of these, but we'll talk about four main mechanoreceptors. These are divided into either rapidly or slowly adapting. And as the name indicates, rapidly adapting receptors are very sensitive to change. They fire in a burst when there's a change of activity and then stop firing. And so they're very sensitive to any motion or movement. Slowly adapting receptors, by contrast, tend to be triggered by indentation of the skin or like a deep vibration. And these have a continuous firing pattern by contrast. So of the type 1 receptors, these are most important for touch. And so we can see here on the slide that these are superficially located. All right, so up here we have these Merkel cells and Meissner's corpuscles right up here. They're kind of at this junction here between the dermis and the epidermis. And Merkel cells are especially sensitive to edges and points. And so when we think about the incredible ability in some areas like fingertips and lips to sense edges and points. So the ability to check or to read Braille and just to, make those decipher between those tiny changes in dots, that would be a good example of a function of Merkel cells, which again are sensitive to edges and points. The Meissner's corpuscles, these are rapidly adapting, and these appear to be more important for initial contact with an object, the sensation, the perception of that, and also the sense of any lateral motion or slippage. So if this cup starts to fall, the detection of that, just that initial movement would be very sensitively picked up by the Meissner corpuscles. There's a lot of overlap, so these receptors are not 100% one function, but these are just some preferences. Now we can see here the type 2 receptors are deeper. So here's a Pacinian corpuscle and the Ruffini endings. All right, and so the Pacinian corpuscles are most sensitive to vibration, especially lower frequency vibration. They're sensitive to deep pressure, and also the ability to detect the weight of an object. Just in general, I'll make a point here between type 1 and type 2. The type 1 receptors have a very narrow, focused receptor field. So they're able to just very precisely identify something. Again, think of ability to detect Braille dots. Whereas the type 2 receptors, which are deeper, requires more pressure to activate them. But they're also more kind of diffuse, not as precise and localized in terms of their receptor field. All right, so coming back to Pacinian corpuscles, a good example just to detect a vibrating object. All right, so you're holding a toothbrush that vibrates. That'd be a good way to activate your Pacinian corpuscles. Ruffini endings are important for stereognosis, which is the ability to determine what an object is when you're holding it in your hand. So again, come back to the cup here, the skin indentation and the ability to, obviously that signal needs to be transduced from a mechanical into an electrical signal that the brain can represent. And so the Ruffini endings would be the important receptors then for what happens in the brain to decipher and determine an object that you're holding. So when we think about pain, pain is something, the sensation or the perception of pain is highly variable. depends on many factors. And so many of you probably know, if you play sports or something, that you can often kind of fight through pain in that kind of a situation, or a fight or flight circumstance, where you're trying to get away from someone. And you just, you kind of shut the pain out for a while. And a little bit, I'll talk about the mechanism for how that happens. I remember Jack Youngblood is a football player many years ago who played several games with a broken leg. And he just described how, it hurt a lot, but during the game, somehow he was just able to overcome and to play through it. Now, pain receptors are quite different than the mechanoreceptors I just talked about. Pain receptors are called nociceptors, and these can be mechanical, thermal, chemical, sensing that type of pain, something that punctures, or hot, cold, or a chemical burn, something like that. So notice, by contrast, compared to these, Pacinian corpuscles, Merkel cells, these highly specialized receptors, the pain receptors are just free nerve endings, which we can see right here. All right, so these are our nociceptors. So we can divide these generally into two big categories, dependent on the nerves that relay that information to the spinal cord and subsequently to the brain. So we have these thinly myelinated A delta fibers right here. We can see these conduct about 5 to 35 meters per second. And these are important for mechanical and thermal. So, a puncture injury, something like that. You step on a nail, obviously that would be mechanical. Or thermal, temperatures especially above 45 Celsius or 115, that kind of a burn injury. So this would be conveyed by the A delta fibers. The polymodal fibers also respond to mechanical and thermal, but in addition to chemical stimuli. And so these are relayed by unmyelinated, what we call C fibers. And you can see that these conduct here at a much slower speed. All right, so we can activate, both the mechanical thermal and the polymodal by stubbing your toe. And I think we've all had the experience. If you really stub your toe, intensely, in that initial just split second, your brain tells you, okay, this is really going to hurt. Now, you're aware of the pain initially, but the real pain, the more intense pain, is going to happen in just a split second later. And that is just an example of these two pathways, right? So initially you get the information from the A delta fibers, 5 to 35 meters per second. But then, the more intense, vivid, unpleasant pain is conveyed by the C fibers, and it happens just a little bit later. Okay, just an illustration of the timing difference there. All right, so we've talked about earlier in the course proprioception, conveyed by muscle spindles and Golgi tendon organs. And we can see that these are relayed by the fastest, most heavily myelinated neurons, the A alpha. All right, very fast. The Meissner's, Pacinian, Merkel, Ruffini endings that we talked about, also very fast, A beta. And here we have the A delta and C fibers. And so we can see a lot of overlap between these two, but we'll add chemical here as something that is relayed only by, or primarily, by the smaller C fibers. And again, remember, all of this here for pain are these free or bare nerve endings. Just another terminology. The sensations here, which are highly localized and specific, like by Meissner's corpuscles, Merkel cells, this is called discriminative touch, right? You can discriminate between a vibration and a braille dot and that kind of a thing. The pain fibers here, A delta and C, also relay to the brain what's called non-discriminative touch, or sometimes called crude touch. Right, and so these are the kind of the less well localizing type of touch. So this information from the C and the A delta fibers comes in, along with all sensation here, into the dorsal horn. And we can see that for the A delta, it synapses in lamina 1 and 5. And I emphasized here in our lecture on the spinal cord the layer 2, the substantia gelatinosa, and that's the predominant area of synapse for the smaller C fibers, and is very important for that type of pain as its kind of first synapse on the way up to the brain. Okay, and so we'll see there are a number of pain pathways, but of course a lot of this is going to feed into the spinothalamic tract. That's the one we've talked about so far. All right, so one thing you probably should know about is called the gate control theory of pain. And this has been something talked about since the 1950s or so. And the idea is that here we have, let's just say, a C fiber conveying some type of pain. So this is going to relay, let's say this is the substantia gelatinosa here, and it's going to relay that up to the brain. Well, there's an inhibitory neuron here, which the pain, it wants to get the signal through. So it's going to inhibit the inhibitory neuron, and then the pain is more likely to pass on through. Now, the gate control theory of pain says that the larger sensory fibers, and so here we have larger sensory fibers, probably a beta are most important here, can actually activate the inhibitory interneuron, and therefore we get some inhibition here on this painful information that wants to get to the brain. So this can shut it down to a certain degree or close the gate. Okay, so a practical application of this. Well, first of all, you've had the experience of stubbing your toe might be an example, but maybe a better one is if you hit your thumb while you're hammering a nail. Okay, and again, you get that immediate and then that delayed pain. But if you notice that if you shake your hand, that tends to diminish the pain. That's what people do when they hit their thumb with a hammer, right? They shake the hand. Well, when you shake your hand like that, you are activating the larger myelinated sensory nerve fibers, and that therefore has a effect of diminishing the sensation of pain, because less pain is bombarding the sensory cortex. So an idea that out of this that became a treatment are TENS units. Okay, and so these TENS units provide an electrical stimulation to areas where patients are having pain. So these patches can be put on the low back or, wherever you want to. The idea here with the gate control theory of pain is you want to activate nerves that are in the area where pain is synapsing there in the dorsal horn. And so that's at least the theory behind TENS units related to the gate control theory of pain and why this may be helpful for some patients. Now, how does pain get up to the brain from there? Well, we've talked about the spinothalamic tract, and the spinothalamic tract, recall this somatosensory strip here. And so pain, whether you hit your finger or you have pain somewhere else, it's going to come to this very precise area of the postcentral gyrus. And so the spinothalamic tract, therefore, is very important for localizing pain and also identifying the quality and the intensity of the pain. All right, there are actually 5 pain pathways that get to the brain. I'm going to tell you about just 2 others. Okay, one other pathway that we haven't talked about yet is the spinal reticular tract. Okay, and this travels right along with the spinothalamic tract. We can see it coming into the dorsal horn, crossing over and ascending right alongside the spinothalamic tract. Okay, but the spinal reticular tract, as its name indicates, synapses on the reticular formation in the brainstem. All right, and so we're going to see this throughout the brainstem, especially in the pons and in the lower midbrain area. So from the reticular formation, this goes up to the thalamus. Okay, they call this here the intralaminar nucleus of the thalamus. When we went through the lecture on the thalamus, we called this the centromedian nucleus of the thalamus, same thing. And from there, now notice the difference. This does not go to one area of the sensory cortex. This really bombards large areas of the cortex. So unlike the spinothalamic tract, this pathway is not really for localizing pain as well, but this has a very alerting function. The whole brain is activated by this painful information. So we use this to our advantage in a patient maybe who's unresponsive. And we want to find out, where is the lesion in this patient? And so we want to alert the patient, because if the patient alerts and they only move one side of their body, that tells us, well, something must be going on in one hemisphere of the brain. And so we can give pain either by pushing on the nail bed with a hard object. That's called deep nail bed pressure. You can take a cotton swab and put it into the nasopharynx and twist it around a little bit. That's very uncomfortable, right? But it doesn't leave any lasting damage. It's very alerting through the anatomy here that we're pointing out right now. Okay, so it's a good way to activate the brain, and you're trying to get some information from your patient about maybe where the problem is. The spinal reticular tract also appears to contribute much to the emotional, kind of the chronic, unpleasant character of pain. Now, the spino-mesencephalic tract, this is a very complicated drawing, and I'm going to tell you exactly what I want you to know about this pathway. So, like the other two, the pain comes into the dorsal horn and ascends to the brain by a variety of pathways. The spino-mesencephalic tract, what do you hear in the word mesencephalic? Remember, embryologically, the mesencephalon is the midbrain. And so this pathway ascends here to the midbrain, and it synapses in this area right here, which is the periaqueductal gray. Okay, and that is really the most important thing that I want you to get out of this slide. Not so much the spino-mesencephalic tract, but the periaqueductal gray in the midbrain, which is loaded with opioid receptors and is best understood really as an interface as it relates to pain between the brain, which talks down to the periaqueductal gray, and the painful information coming up through the spinal cord. All right, so it's an interface. We know that electrical stimulation of the periaqueductal gray diminishes pain. There's analgesia. And so what happens is these descending connections with the periaqueductal gray, and this is very complicated. I decided not to go into these different areas and different zones of the periaqueductal gray. But the basic point is this: if we activate the periaqueductal gray, then it has connections down to the dorsal horn of the spinal cord to diminish pain. So the example of fight or flight, or an athlete being able to fight through pain, well, that would be the brain stimulating the periaqueductal gray to sort of shut down for a period of time the sensation of pain. Also, the placebo response, which is very high. When I was a neurology resident in the 1990s, most of the studies done on medications for headache back in the 80s and early 1990s were not done with a placebo group, which would be just unthinkable today. And so you had all these medications that were on the market for headache that were not studied against a placebo. And the placebo response for migraine in some studies can be up to 40%. And so later, I recall a well-known medication was finally studied against a placebo, and the placebo did just a little bit better than this medication that had been on the market for some time. All right, so placebo involves the insular cortex is really important in that, but it activates endogenous opioid receptors, or endogenous opioid release, which stimulates opioid receptors here in the periaqueductal gray. All right. There are some studies showing the effect of acupuncture also is some of it relates here to stimulation of the periaqueductal gray. Now, another very busy slide here showing you opioid-producing neurons on the left and receptors on the right. And obviously, I don't want you to memorize all of the endogenous endorphins here and the receptors. You can see it's rather diffuse, right? But there are some areas that are probably more important than others. So one here, of course, is the periaqueductal gray. Okay, lots of opioid receptors there. But there are also lots of opioid receptors here on the dorsal horn and lots of opioid receptors on the distal portions of peripheral nerves. So some of the more common opioid medications would be morphine and hydrocodone. Okay, but again, we've got all these endogenous opioids in addition. So a condition practical and worth knowing about is called opioid-induced hyperalgesia. And we see this all the time in the clinical setting. And this refers to what's called a state of nociceptive sensitization. And it's due to chronic, really overuse of opioid medications. And it appears from several studies that if patients use opioids more than about 7 or 8 days per month over a period of time, that a paradoxical response occurs where pain, which initially had been helped by the opioid medication, will actually get worse. And we see this most often with patients that have migraines, that take opioids and then over time develop just a severe daily headache that never goes away. Their migraine frequency increases, and really the only option in that situation is to come off of the opioids if things are going to get turned around at all. Many studies showing people can develop chronic back pain as a result of being on opioids for a period of time. So typically, we try to find other better options if we're going to need something for long-term pain. All right, now, if you take an opioid because of a dental procedure for a few days or something, that's not a problem. Okay, we're talking about chronic use. Naloxone is a medication which is a competitive opioid receptor antagonist. So if we have someone that would overdose on opioids, that could be given. Interestingly, naloxone blocks the placebo response, right? So it would block the endogenous opioid response to placebo. Now, before we get into some pain syndromes, let's just go through some definitions first of all. Physiologic pain is pain where we have a normal central and peripheral nervous system. Okay, you sprain your ankle or something like that. The nerves obviously send that information up to the brain, okay, but we have a normal nervous system and it lacks the features of neuropathic pain, which I'm going to describe right now. So neuropathic pain is where we have an abnormal nervous system. And this can be anywhere from the distal peripheral nerves and receptors up through the peripheral nerve plexus, roots, dorsal root entry zone in the spinal cord, and up to the thalamus. And so a lesion anywhere along that course has the potentiality of causing neuropathic pain. We've talked about thalamic pain syndrome, okay, where patients have a stroke in the thalamus and have a chronic burning, stinging pain on the opposite side of the body. Classically, neuropathic pain has an electrical quality. Okay, there's a jolting, shocking, stabbing quality, and burning and tingling would be two other very common features. Numbness probably should add as another classic feature of neuropathic pain. We'll go over some terms. I included more in your handout, which I won't ask you about, but these are often used imprecisely. But here are the most important ones that you probably should know about. First is the term hyperalgesia. Okay, this is a classic feature of neuropathic pain where there's a increased perception of pain for a given sensory stimulus. So there are three hallmark features of hyperalgesia. The pain can be spontaneous. Even just a little trigger, or sometimes none at all, can result in pain. Allodynia, very important you know what that means, because that is very specific for nerve disease. Allodynia is a lowered pain threshold that even a non-noxious stimulation causes pain. So in just a few minutes, I'm going to talk about peripheral neuropathy pain. And those patients will say things like, boy, just the bed sheets rubbing on my toes is painful. Okay, that's a non-noxious stimulation, but it causes pain. And that's allodynia. Or another common complaint is when they walk, they feel like their socks are bunched up under their foot. There's a rock in there. Even the socks can be uncomfortable. All right, there's also a degree of sensitization in hyperalgesia where a previous painful stimulation are now even more painful, even more sensitive to that painful stimulation. Hypoalgesia and hypoesthesia are closely related. Hypoalgesia is where there's a reduced pain perception. So an example of that would be syringomyelia. So remember those patients that have a central cavity in the spinal cord have a loss of pain and temperature in the arms and legs. And so a patient cooking, and they can't tell that when they're getting their hand too close to something hot. So that would be a reduced pain perception. Whereas hypoesthesia is just a reduced perception to all sensation, not just pain. So numbness, again, neuropathy, which we'll talk about. Patients will say, my feet are numb. And they'll say when they take their shoes and socks off, put their feet on maybe a cold floor, they can't sense that it's cold. Okay, so that would be an example of hypoesthesia. Dysesthesia just literally means an abnormal sensation, but this is used typically to describe a painful abnormal sensation, like a painful tingling or burning. And that's very common for neuropathy. A lot of overlap with the term paresthesia, which is generally used to describe numbness, tingling, burning, and often a kind of a prickly sensation that goes along with it. So let's go through some specific pain syndromes. Peripheral neuropathy is exceedingly common and very painful, usually. And in the second year course, we will go over dozens of different types of peripheral neuropathy. Diabetes is far and away the most common cause in this country and in the world. And the classic feature of more than 90% of peripheral neuropathies is what we call a stocking glove distribution. And I'll say more about this in the second year neuroscience course, but basically the longest nerves in your body are the ones that are most affected. And so the longest nerve in your body goes from the low back down to your toes. And that's why symptoms almost always start in the toes with burning, stinging, tingling sensation, and then over time in the fingertips. Okay, so if you have a patient complaining of numbness, tingling, burning in the toes and in the fingertips, that patient has peripheral neuropathy. And there are many mechanisms, but it all depends on the etiology. And we'll go into next year the etiology of diabetic neuropathy, but there are all kinds of vascular, metabolic, toxic, number of medications or have a toxic effect on the peripheral nerves, autoimmune, hereditary, and so I don't expect you to know this for now, but there are dozens and dozens of common mechanisms for different peripheral neuropathies. Now, a couple of conditions here that I've been asked to cover in neuroscience because it really isn't anywhere else in the curriculum, but it's sort of a hot topic for boards. One is phantom limb pain. So these are patients that have had an amputation. And I saw a patient years ago who was in a vehicle that rolled over. I think he was in a sand dune. And his arm was amputated in the process. And he would tell me, and he was amputated way up at the shoulder, that sitting in a chair, he could feel his hand resting in his lap. Now that's phantom limb sensation. There was no pain along with that, right? Compared to phantom limb pain, where now there's burning and, stabbing pain, not just the sensation of the limb being present. The mechanism is not well understood. It used to be thought this is due to a distal, what's called a neuroma, which forms at the very end of the amputation. And it was felt that was sending sort of the false signal to the brain. And that still may contribute, but it's clearly more than just a distal neuroma. It appears there's kind of a bombardment of the dorsal horn, and some hyperexcitability there may be a factor. And a number of interesting studies have looked at what's called cortical remapping in patients that have phantom limb pain. So here we can see a normal individual moving their arm, supinating and pronating. And so there's activity in the brain in appropriate areas. Here we can see the sort of the motor sensory strip here. And so in the patient that has the amputation, however, notice that this activity, or the attempt at this activity, results in a larger activation of more widespread cortical areas. And so here we can see the hands and fingers, but in an amputation, the patient doesn't have a hand or fingers, on that side. And so the other areas of the brain, here for the lower extremity and the face and the lips, may take over that part of the brain that used to be dedicated to the arm and hand motor or sensory function. And so it's felt that this sort of remapping or cortical reorganization is probably also responsible for not just phantom limb sensation, but for phantom limb pain. All right, another condition here is called fibromyalgia, or a chronic pain syndrome. Really, this shouldn't be considered primarily a neurologic condition, and it's very poorly understood. Fibromyalgia patients have chronic diffuse pain and a hypersensitivity to pain. And so they're very sensitive to touch, and they have used to be different diagnostic criteria about how many points you could push and how hard you would push to elicit pain. It is highly associated with depression, post-traumatic stress disorder, and anxiety, and patients have many symptoms that go along with depression, PTSD, and anxiety. So fatigue, forgetfulness, insomnia, dizziness, headaches, irritable bowel, bladder syndromes. These are all symptoms that in studies correlate highly with depression, anxiety, PTSD, and they're present in most patients that have fibromyalgia. So depression is certainly a negative feedback loop on the pain experience. Patients that have depression statistically much more likely to have pain. And we know that emotional stressors have a role in triggering the fibromyalgia syndrome. So mechanism is not well understood. There clearly is what is called a central sensitization, where there's a change, a distortion of how the brain processes pain. What isn't known is sort of this chicken and egg debate. Did the depression occur first and that got this going, or did the pain start and then the depression was secondary? So there's a lot of debate about that. It is known that negative thoughts provide, again, this kind of a bad feedback loop and tend to aggravate pain. So anger, which in these patients is often bottled up, is felt to have a sort of a negative consequence of this. Catastrophizing, which is really an exaggerated view of one's problems and a kind of a monofocus on that, is also problematic. These patients often have a sense of perceived helplessness. There's hypervigilance, which is usually just really a selective attention to threatening information that goes over and over that same loop. And so that's why treatment involves cognitive behavioral therapy to try to undo some of these things. Emphasis on just a healthy lifestyle, including diet and exercise, and a number of medications, including antidepressants, help not just with the depression, but also the pain that goes along with fibromyalgia. All right, another condition is known as chronic regional pain syndrome. This used to be called reflex sympathetic dystrophy, not a very good term. I mention it just because some people still use that older term, reflex sympathetic dystrophy. Okay, so I'll give you the definition. It's an array of painful conditions that are characterized by a continuing regional pain that is seemingly disproportionate in time or degree to the usual course of any known trauma or other lesion. The pain is regional and usually has a distal predominance of abnormal motor, sensory, vasomotor, and trophic findings. All right, that's as concise a definition here as I could find. So type 1 chronic regional pain syndrome makes up almost all cases, and this is where there's no nerve injury. So the patient had a fracture, that's the most common cause, or some sort of distal trauma, but the nerves actually are functioning normally. Okay, we can see this is more common in women, and there have been numerous studies showing that there are predisposing personality traits and psychosocial issues that tend to make someone more likely to experience this. So there are a lot of mechanisms not well understood. Substance P, which is an important neurotransmitter for pain, seems to be involved in this, probably other inflammatory mediators, and there's an increase of cytokines and inflammation as a result. So patients with this condition have pain, which is burning, stinging, has features of hyperalgesia, and including allodynia. Okay. Again, the nerves are normal, typically, and so it can be hard to sort this out, but when you check strength in these patients, because of pain, they're usually not able to give good effort. And so we call that a pseudo weakness. Okay, again, it doesn't mean the patient is faking or anything like that, but because of pain, they're unable to give good effort. Okay, so we think if they didn't have pain, then they would have normal strength. Okay, there is also autonomic involvement and subsequently skin color change, usually kind of a purplish mottling, and often some swelling and change in sweating. That is all a feature of some autonomic process that's involved here. So this has a differential diagnosis. So we want to rule out a local infection as a cause. Next year you'll learn about something called compartment syndrome, which should also be considered. That would be a serious condition you wouldn't want to miss. And if we have a disease of the peripheral nerves or arteries, that can mimic this syndrome as well. Finally, this condition is something that is talked about a lot in medical legal circles. And so these are just terms that you should know about. It will come up quite a lot in neurology as we get more into clinical neurology. But conversion disorder is the patient is not purposefully doing something. This is involuntary, and it would be a subconscious manifestation of stress. So I saw a patient, a very sad case years ago, a lady who was abused by her husband, and she actually stabbed him and came into the hospital with severe pain in the arm, where she had the hand that she had used to stab him. And she was very guarded, couldn't move the arm. She appeared to have a little swelling, even some color change, but everything appeared to be normal. There was, really no trauma to the limb. It became quite clear and with therapy that this was a response to the stress of that circumstance. That's what we call a conversion disorder. Okay, factitious disorder, there's now a voluntary, a conscious manifestation. And so this would be more taking on physical symptoms to assume a sick role, perhaps in a dysfunctional family or something like that. Malingering would be where there's a purposeful falsification of an illness for some secondary gain. And so I saw a patient years ago who fell in a grocery store and had a whole bunch of problems as a result of that. But one of them was, he complained a lot of leg pain, and this appeared to be not genuine. It was for the purpose of a lawsuit against the grocery store. And so these kinds of condition will often come into play or into the discussion in certain situations of limb pain. Okay, finally, we'll say just a little bit about migraine. The aura of migraine, which is seen in 25% of patients, but even in patients who aren't aware of an aura, there is something happening in the brain in these patients prior to the headache, and we think that's a very important clue in terms of the pathophysiology of this condition. Sorry about my dog in the background there. So patients with migraine often have some drowsiness or mood changes prior to the headache. And in a classic migraine, patients have very distinct visual symptoms for usually 10 to 15 minutes prior to the headache. And so these can take a variety of different forms. Can be kind of a central black area or a donut hole here. These can be bright, jagged edges. Fortification spectra describes what we're looking at here. If you look at these old castle formations from the Dark Ages. So there's a whole bunch of variety, but what is it in the brain that is causing this? And so when I was a medical student, it was all about, well, either the blood vessels constrict or they dilate. And that's what, the vasoconstriction is the aura, the vasodilation is the pain. And we know now that any change in terms of constriction or dilation of blood vessels is merely an epiphenomenon of what is really going on, which is neurovascular instability. So the neurovascular theory is our best explanation of what's going on in migraine, and it isn't known what sets this off, but there's what's called a cortical spreading depression in the brain. Okay, and there's just this wave of neuronal and glial depolarization. And during that time, there are massive neurochemical changes that happen in the brain, and there's vasoconstriction of blood vessels, and this is when patients have their aura. Okay, so their visual change, or there are many other auras. In the next year, I'll show you a video of a reporter who was giving a news report, and she suddenly can't talk, and that was her aura. Or patients can have a hemiplegia, or any variety of things that depending on what area of the brain is involved. But visual is most common. And so this cortical spreading depression appears to be intensely activate trigeminal nerve afferents, and you actually have a disruption of the blood-brain barrier in this process. Now, substance P we've talked about as an important neurotransmitter for pain, but for migraine, CGRP, calcitonin gene-related protein, is the hot topic, the most important neurotransmitter, it appears, as it relates to migraine headaches. CGRP at neurovascular junctions causes inflammation, and it appears much of what seems to be going on in terms of migraine, the production of the pain, is related to CGRP with subsequent neurogenic inflammation. So the vasodilation then is when patients have the headache. So just as an example, we'll talk about many medications for migraine, but one that's been around for a long time is sumatriptan. There are now about 8 or 9 medications in the sumatriptan family, but these are serotonin agonists. And previously, we've emphasized how that maybe affects blood vessels in terms of constriction and all of that. But Now it's known that when you take sumatriptan for migraine, it actually brings the CGRP levels down. Okay, that may be the more important role or mechanism of sumatriptan. And within the last 18 months, numerous medications have come out, monoclonal antibodies against CGRP. And these are very effective. Patients can take them as an injection every 4 weeks, and it actually works to prevent migraines from coming on. All right, so that's just a little overview of pain. Hope everyone is well, and look forward to this whole coronavirus situation being over so we can see you in class again. All right, take care.